Recording in progress.
Turn your volume all the way down.
But I need this mic, right?
It's on mute. Yeah.
So should be good. Okay. Good morning, everyone. Welcome to our distinguished visiting lecture grand rounds for May. And it's a pleasure to have such a nice turnout, both online and here in the room, in Paula Clayton room. And it's a real treat for me to introduce a colleague who is in the same research area that I am. So of course, I think extremely highly of her work. I can tell you that even before hearing her talk. Dr. Sherry Chan is an associate professor at the University of Hong Kong in the Department of Psychiatry there. And she has spent her career focused on early psychosis, many aspects of it, ranging from the clinical and epidemiological aspects of early psychosis to cognitive and behavioral aspects to predictive factors in terms of long-term outcomes. Sherry has led a number of very interesting projects and has also been a really highly contributing member of a team there that has been focused on ongoing longitudinal studies of early psychosis in Hong Kong. And, you know, one of the things that's sort of been most striking about the work they do there, I don't know if Sherry will allude to it or not today, but how interesting it is to learn about the approaches to early psychosis in different cultures and in different healthcare systems. Because in Hong Kong, given the nature of kind of a smaller population, a more homogeneous culture, a different healthcare system, they are able to bring individuals in for treatment, people, the typical time between, you know, the onset of symptoms and someone coming in for treatment is, I remember you telling me 12 weeks, something like that, several months. And in the United States, in studies, the average time is more like 72 weeks, over a year. So it's just, it's an indicator of how much the trajectory of a serious mental illness can be affected by factors which have nothing to do with the biology of the illness. Anyway, part of the wonderful work that Sherry has been heading up and participating in is the ability to follow cohorts of young people who've experienced psychosis over time and really understand some of the factors that can contribute to worse or better outcomes. And today she'll be talking to us about kind of some of the factors that are contributing to self-harm and suicidal ideation in these young individuals. So Sherry, it's a real pleasure to have you here. I've known about your work for many years and we get to have you here in person today. So thank you and we look forward to your talk.
Thank you so much, Sophia. I hope that everybody can hear me. So it's really a great pleasure and honor to be invited to come over here to give a talk in the grand rounds with regard to my work. So today I'll be sharing with you the key topic on the suicide mortality in the first episode psychosis, schizophrenia spectrum disorders patients, and particularly on the impact of our local early intervention service on the suicide mortality. I will also be talking about predictions of self-harm in patients in the early phase of their illness within the our setting. Oops.
I think you have to click. Got it.
Got it.
Yeah.
Is that yours?
Is it mine? No, I already clicked, got it.
That's thanks, Jewel.
Oh, listen, the rest of you as usual.
That's right.
Right. It's dissociable for solving the problem. I just want to point that out.
So just a little background about suicide modality and self-harm in schizophrenia. So the median standard mortality ratio, SMR, of all-cause mortality among patients with schizophrenia is about 2.5. That means close to 3 times of our patients had close to 3 times more suicide mortality, standard mortality than the normal populations. And the median of SMRI for suicide was actually close to 13. That means 13 times higher in our patients. So it's actually a very important and crucial issues for our clinicians and also researchers to help our patients. And so the lifetime risk of suicide among patients was about 4% to 6%. Usually we talk about 5%. The population attributable risk of suicide was estimated to be about 8.99% among those patients with schizophrenia. What means by that is that in our population, the suicide, all the people that suicide in our populations, around 9% can be actually attributed to patients with schizophrenia. So you can see that suicidalities of patients with schizophrenia is also a very important population issues in our society. And then we also know that suicide is more common during the early phase of the illnesses. In fact, many studies have shown that the suicide rate is much higher in the first episode patients than the chronic patients. Here, just one citation is about 2.7 times in patients in their first episode. So that little reviews of the literature suggesting that this is a very important aspect, and also even more important is to help the patients during that first stage of illnesses or understand the suicide mortalities and self-harm in the early stage of the illness. So what are the other characteristics of suicide and self-harm during the early stage of illnesses? There are several of them. The first is that I've already mentioned there's a lot of patients that most prominent stage of their suicidalities happens during the early phase of the illnesses. And you can see this is the studies from the first, on the left-hand side is the study from Canada, which suggesting that not only about 16% of people actually has record one suicide ideations during the first 24 months of their illness, but also you can see there's a different trajectories. So some people getting more and some people actually getting lower or lesser over time. Another very interesting phenomenon, which was shown on the right-hand side of the PowerPoint, is that there are high fluctuations of suicidal risk during the initial period. So this is actually the study from EPIC from Australia. You can see that over the first, again, 2 years, it goes up and down. This is a group level analysis or reports. And you can imagine everybody with clinical experience, you can see that longitudinally, people with first episode psychosis, they goes up and down, suicidality as well as other symptoms, positive symptoms, depressive symptoms, and negative symptoms. So therefore, traditionally, when we look at suicide, self-harm events or suicide ideations or mortalities, well, mortalities, there's only one sort of event can happen in one's life, but then in any other suicide event, you can see that it's going to be a ups and down fluctuating cause. So the cause of those suicide events is actually very important for us to study. But most of the literatures nowadays is using a very categorical dimensions or categorical approach, whether you have suicide attempts or you don't, or sometimes just giving you numbers, how many times that you had suicidal ideations or suicidal attempts in the past a period of time. So that actually reduces some of the information's abilities for us to actually look at those phenomena in detail. Risk factors of suicide or self-harm actually has been studied for a long period of time. And the key researchers, I think most of you will know, that's been studied, the suicide risk factors for suicide attempts and suicidal ideations will be Keith Horton. So there's many literature reviews on this aspect. And so here I've listed most of the consistent findings of the risk factors for suicide attempts and suicide. But be mindful, most of the studies early days were on suicide in general. And then what about suicide in the first episode psychosis? Again, there are quite a few studies actually looking at this particular stage of illnesses in terms of what are the key risk factors. And you can see the differences between this more narrower diagnostic categories or phase of illnesses compared to more general is more on the symptoms, the depressive symptoms, psychotic symptoms during the first and the second year of follow-up. So here gives you more of a longitudinal perspectives of the importance of these symptoms during the first stage of illnesses and how they can contribute to the suicide risk during this phase. What I try to introduce here is more of a longitudinal perspectives of the symptoms as well as suicide modality or suicide attempts or events. And also potentially the dynamic interactions as well. So what about, again, then what about early intervention? What has early intervention done to the suicide risk in our patients? And not very many studies that has been done, partly because suicide mortality itself is a very rare event. So you do need a large sample size to actually be able to have sufficient power to study this particular phenomenon. Internationally, randomized controlled trials, the biggest sample so far is from Opus. They originally have over 500 population study samples, but for their studies, after 5 years, they did not actually find any statistical significant differences in the mortality or suicide rate between the early intervention center care groups. Again, power was an issue because the numbers was actually fairly small in this cohort in this particular period for 5 years. And then suicide mortality and self-harm, sometimes people, if in the field of suicide, study of suicides, they tend to think that's slightly different because self-harm, it can be intentional self-harm, or it can be self-harm without an intent of suicide, ending their life. So it might be a little different. And then, but then clinically, nonetheless, what we wanted to do is that to be able to identify self-harm risk within an actionable time frame so that interventions can be provided. And then it relies on, at the moment, mostly on the clinical judgment, and then with a little bit of assessment tools. But on the other hand, with as a clinician, you probably have sometimes know that, or studies have actually shown the compliance of the using the assessment tools and then performing a risk assessment of suicide are not that great sometimes. So it can be quite questionable in terms of how good the compliance are. And also the assessment tools that tend to be questionnaire based, so that, which then means largely self-reported at that particular time point from the patients or their caregivers. So then it comes to some researchers recently started to think about whether it's possible to use machine learning models, more data-driven approach, whether that could help us as a clinician to predict the individuals who might have a higher chance to have a self-harm event in the past. In general, the prediction model is actually good in terms of classification, that is categorizing those people who had self-harm and not self-harm, but not so good in predicting individual events in the future. And then also mostly of these studies in terms of prediction models have done in the general population, but not so much in the patient groups in general, specific patient groups in general. And then also there hasn't been many studies focusing on using prediction models to look at the early stage of illnesses in terms of predicting self-harm. And then I think there's not many studies have been looking to the role of symptom fluctuations. As I've already mentioned in the previous slides, that depressive symptoms and positive symptoms during the first 1 or 2 years actually are very important to the suicide risk in the first episode patients. So these are the literatures that I will recommend for reading in this particular topic. A little bit of introductions of early intervention services in Hong Kong, which was developed in 2001. The name of early intervention service is easy. It's very easy to remember. But then at that time, the basic conditions before the establishment of early intervention service in Hong Kong is that our standard care service are relatively more hospital-based, less community support, very little community support. And then we had a long waiting time, partially contributed to the lower manpower. We have only 300 psychiatrists at that time serving 7 million population. And our severe mental illness are all managed and treated by the publicly funded psychiatry services in Hong Kong. So that's with that background, the early intervention services in Hong Kong was developed and implemented as a region-wide service in Hong Kong in 2001. So it covers the whole Hong Kong area. It's around the same time we have also developed the electronic centralized medical record system, which document all inpatient histories, outpatient consultations, service utilization, investigation results, and medication prescriptions. These systems really help us in the subsequent studies for us to extract information. So we can extract information from these electronic health records to provide more higher resolution clinical information to help us to evaluate the risk factors for the different outcomes, including suicide and suicide mortality. So the service at that time, we had 4 intervention teams covering the whole Hong Kong area. Each team, we have 2 psychiatrists. We also have key workers, and you can see very few clinical psychologist sessions. And then we use a pipe program, and then our caseload is really high, probably the highest actually among all the early intervention teams. It was 1 to 80 caseload. 80 is the caseload for the key workers, but now we dropped to 1 for 50. And we also form a close relationship with the local NGOs for the referral systems and also for integrating the vocational and rehabilitation for our patients during the service period. And then we focus on patients of age 15 to 25 and then having their first episode. And here's the exclusion criteria. So we excluded people with substance-induced psychosis and organic psychosis and those who received medication treatment for over 1 month. And then our service at that time was 2 years, followed with a transition period to the standard care service. And our service now actually in 2011 has been extended to adult population. So now we actually cover from 15 to 64. And then our service is also being expanded to 3 years. So, but then the results that I'm presenting today was mainly focusing on the first phase of our early intervention service. The short-term outcomes, we use a historical control studies methodologies, and then we demonstrate that the benefit was across all the domains of outcomes, symptoms, service utilization, hospitalizations, and functioning. The reason that we have to use historical control studies is because the service was region-wide, therefore we couldn't actually do a concurrent control, but we can show you the sampling approach, then you can get more sense of that. We've also demonstrated in several studies in terms of our long-term outcomes, that is 10 years of first episode patients and the impact of early intervention service. In a summary, in a nutshell, is that similar to OPUS studies, we didn't actually find any effect of early interventions on a cross-sectional assessment of clinical remissions and recovery. Also, we didn't see any differences in terms of a trajectory of negative symptoms. But we do see patients had a better employment outcomes over the years. It's a trajectory of employment. And also patients have, more patients had relapse-free period. Also, a number of people managed to be relapse-free over 10 years. So we do see, different from OPUS studies, we do see some impact, long-term impact of early interventions on some of these longitudinal trajectory outcomes. So here's the sampling characteristics, or sampling methodology. So we had in our studies that I'm going to present in terms of the mortality, we have 670 patients of first episode schizophrenia spectrum disorders consecutively entering the early intervention service for the first 2 years, 2001 to 2003. And then we matched age, gender, and diagnosis with another 670 patients of first episode schizophrenia spectrum disorders who entering the standard care service just a year before, just immediately before the early intervention services, also 2 years, 1998 to 2001. So we, based on using the centralized electronic health record systems, we managed to obtain the demographic informations and baseline characteristics, age of onset, gender, years of education, and also quite a bit of characteristic during the DOP period, and the suicide attempts as well during the DOP, positive, negative, and depressive symptoms at onset.
Can you just define DOP, because not everyone in the audience may know that term?
DOP is the duration of untreated psychosis. Basically, there are different ways of defining duration of untreated psychosis. In this particular studies, we define that as the duration between the onset of the first psychotic symptoms documented till the end when they have effective treatment determined by the clinicians. So that's the duration of untreated psychosis. And then we use CGI to measure the clinical symptoms, positive, negatives, and depressive symptoms. And then we also did collect the informations at the monthly basis over the first 3 years, 36 months. The informations we collect, including daily defined dose of antipsychotic medications, adherence to medications, number of relapse using the operational definition, hospitalization, suicide attempts, obviously it's documented suicide attempts, and all the measurement CGI scores of positive, negative, and the depressive symptoms, and so forth. We then collect mortality informations over the 12 years from the clinical records in order to get a detailed cause of death. So we also obtain information from coroner's court reports. And then, so the cause of death was categorizing according to the ICD-10 definitions. So here's the demographic information, just to show you the comparison of the standard care and the early intervention populations. So since we match the age, gender, and diagnosis, so there's no much differences you can see. But you can see that also that the age was pretty young, so mean age was actually around 21. And there's a differences in terms of education levels and the age of onset, as well as the baseline positive symptoms. So here's the results on the 12-year suicide mortality. One characteristic of Hong Kong is that you can see from a little background of the pictures that we have very high buildings. So the mode of suicide, jumping from height, is the most prominent approach that people took. And then we can see that from a number perspective, around 49 patients committed suicide successfully in the standard care group, and then 28 from the early intervention groups. The standard mortality rate for all-cause mortality for both groups are actually pretty high compared to the international standard. And for the suicide SMR of suicide, even for the early intervention group is also pretty high, 28. That means 28 times higher of that particular age group and gender population sector of that particular period. So it's actually very high. Fortunately, we actually do find significant differences between early intervention and standard care. You can see the Metacognition test was actually significant. But as you remember, we've seen that the standard care group and early intervention group, they do differ in some of the parameters like age of onset and education. Therefore, we also did a propensity score adjusted cost model regression to look at the to look more detail in terms of whether the standard care and early intervention group actually indeed differ from each other, control or taking into account of all other variables. And then we still find significant differences between these two. But then we also wanted to look at whether would the differences only happened during the first few years, or whether the difference actually extended in the later few years, because our early interventions was only 2 years plus 1 year's transition, right? So then we also look at that. We actually find the main significance was actually during the first 3 years. The next 9 years, we did not actually find any significance between the group. So we can say that the main effect of early intervention to reduce the suicide mortality happens during the first 3 years. But the good things, another perspective, another interpretations of the result is that there's no catching up. So people who we managed to prevent, those who have higher risk, the later stage, there's no sort of a catching up effect as such. I'm also interested to look at if there's any, so there seems like there are differences in terms of early suicide versus the later suicide. Would that be different predictors, factors contributing to the early death versus the later death? Here you can see what's interesting here, a little figures is that altogether, both standard care and the early intervention group adding together, you can see that 34 people died during the first 3 years and 39 people died during the next 9 years. They are of similar numbers. So you can see the number of people who died in the first 3 years is actually quite significant. So looking at the first 3 years, the number of suicide attempts during the DUP and the number of suicide attempts during the first 3 years were significant contributors or associating factors for the suicide death during the first 3 years, which suggesting not the number of suicide attempts during the first 3 years, which is actually quite consistent findings compared to other research. But what's interesting is that the DUP period is very important, which also suggesting that more work needs to be done to reduce our DUP, to hopefully that we can catch our patients earlier during their DUP periods when they are before their first perhaps suicidal attempts. For the next later suicide death, the 9-year suicide death, and then we can see that it's premorbid occupational impairment and the number of relapse and compliance, which during the first 3 years, which were significant contributing to the suicide death in the later stage, 9 years. So therefore, this actually tells us that compliance is probably also related to number of relapse as well. So medication compliance here we are talking about. So which suggesting that it's really very crucial for us to have intervention in our first episode patients to reduce the number of relapse during the early stage. We might not actually see an immediate impact to our patients during the first 3 years, but we will actually see the impact of reduction of relapse during the later stage of illness. And this number of relapse during the first, we actually show many other studies actually very important contributors to poor outcomes in the future. But also it's interesting to say that the differences in terms of the contributing factors for early suicide death and the later suicide death. So suicide attempts during the early stage of illness seems to be no longer that significant to predict the later suicide death in our study. So second piece of work that I'm going to introduce you is about self-harm during the early 3 years of the same cohort, actually, the 1,234 people. So here we try to look at deliberate self-harm. And the definition of deliberate self-harm in this study is that anyone who had documented self-harm behavior, we do not take into account of their intention. So it could be intended to commit suicide. It could be intended for other things. So we just obtain the information of the number of whether they had a self-harm behavior or not over the first 3 years. And then taking away people who actually committed suicide during that 3 years. So our number of subjects going down to 1,195. And then we have around 187 people who had ever had self-harm behavior during the three years. So this piece of work, we are trying to look at the predicting factors of deliberate self-harm during the first 3 years, and also whether we can predict using prediction models to predict the deliberate self-harm. And then, so we can see that this is just a simple comparison. And we can see that apart from all the other factors that typically appear in the studies in terms of risk factors to predict self-harm, we also try to look at symptoms. Apart from the average symptoms over the first 36 months, we also look at the variabilities using a mean square of successive differences, the MSSD, which was computed to represent the instability of the symptoms, positive, negative, depressive symptoms, and so forth. So one question we wanted to answer is that whether this fluctuation, instabilities of symptoms has extra information to predict deliberate self-harm of patients during the first 3 years. So therefore, we build 3 models using hierarchical logistic regression model. The first model, just using the baseline informations to see, to predict the self-harm. The second model, we actually take into account of the average symptoms during the first 36 months. And then the third model, M2, we added the instability, the MSSD, the symptom instability into the model. So we wanted to know if the additions of these symptom instabilities contributing significant to the model. Then we actually compared the 3 models. The M2 models was actually significant better than the M1 models in terms of predicting the deliberate self-harm over the first 36 months. So you can see that the M2 had a lower penalty terms compared to M1. So it's a better model and preferred model. So then we go down to use the random forest classification models, a little of machine learning approach to see whether we can, whether we can have a better prediction with the all informations, including adding the MSSD. And you can see that the baseline information is already predicting around 0.65. But by adding the MSSD, the prediction goes up to 0.77. But as I've mentioned, that this is the same as the classification model. So it's basically, as I mentioned before, most of the classification model was pretty good, 0.8 or above in predicting or classifying people who had self-harm or suicide or not. So we also found that. But then we also find that adding the MSSD seems to have adding more information, more value towards the prediction model in or classification models in teasing out people with, separating people with deliberate self-harm versus those who did not. So finally, we wanted to, as I mentioned, actually look at prediction future events. So here we did something more complicated. So we tried to build 4 models that you can see in this panel. So using 6 months prior information to predict future 6 months self-harm events. And then also another model is prior 6 months to predict future 12 months deliberate self-harm events. And we actually use the same random forest classification model, but then with a sliding window. So like shifting across the time frame. And we also tried, because the reason that we initially tried the 6 months, as I mentioned, it's a actionable time frame. So we tried to gather, so using 6 months to predict 6 months. But then we also tried the 6 months and predict 12 months, and also 12 months predict 6 months, and 12 months predict 12 months. Across all panels, the 4 prediction models, generally we have 0.6, you can see here, 0.6 AURC in predicting the deliberate self-harm event. But the best model was actually this one, the panel A, using prior 6 months information to predict the month 11 to month 23 period. And then during that period, it's actually go up to 0.7%, 0.7, the AURC goes to 0.7. My understanding is that actually, if from a clinical perspective, the first 6 months to 1 year, people generally are very warming up to our clinical interventions. They are more engaging, and then they are more protected to some extent by the services, by their family, etc. The next 1 year is a period that they trying out different things. Say, for example, they try to stop the medication, they try to go to work, they try to go to schools. And those were the time that there would be more stresses. So that's the more tricky period. And then a lot of things can happen during the 2nd year. And then during the 3rd year, even more things could happen. And then, so that comes to our limitations. So what we didn't look at is that in the, so features or prediction risk factors we didn't look at is the live event we didn't look at, which I believe is also very significant contributors. And then the longer the time goes, so if we shift in the windows, the time windows go towards the later period, the more things could have happened, more live events could have happened, because the 1 year period or closer to the onset, we probably a lot of symptoms, a lot of clinical responses might have already been accounted to the live event happens before, because we know that live events could be one of the important trigger factors for the onset of illnesses. So that might have already contributing to the initial onset, perhaps also reflected in their response to the treatment and etc. Whereas the longer the time goes, the more live events during the period of the illnesses might have contributed to the later stage, which we did not account for. So that's the interpretations of my sort of explanations for the interesting findings that we have, that only the 11th month to 23rd month is more important or better predicted by our prediction model. But then also one thing that's important for us to remember I would mention the conclusion is that the importance of the longitudinal informations in the prediction in our outcomes. One limitations I do need to mention here is the generalizabilities, because our populations only, this particular studies was only conducted in a age group of 15 to 25. And also we've excluded substance-induced psychosis. We also, in our population, our substance use rate was pretty low. It's only about 9% of people who has actually used any substance. And also a lot of key risk factors of suicide and self-harm were not assessed, such as negative cognitions like hopelessness, personality traits, family history of suicide, any significant life events. But nonetheless, even with our very limited features that we can extract from the electronic health record, we do achieve not so bad prediction models for our people. The number of features only 25 altogether. And then, but then the conclusions based on the two studies I've presented today is that early intervention may be able to reduce the suicide death, particularly over the first period of time, the early phase of the illnesses. And that it's very important in a public health perspective, because the overall suicide rate in the population can actually be reduced by almost 50% if the suicide rate among the individuals with mental illness were to be reduced to the level of that of the general populations. So then, there's on average, the suicide mortality is actually 13 times higher, and in our population is close to like 30 times higher. So it'd be good to reduce that. And also different factors, there are different factors for contributing to suicide death at different stage of the illnesses. And instability of symptoms, both positive and negative symptoms, during the first stage of illnesses are actually very important factors and extra informations for us to look at the outcomes of our patients. And also with our prediction or using the random forest model, we can build a sliding window kind of a models to predict self-harm. So therefore, it might be possible to develop a data-informed prediction tool using ongoing clinical information in predicting patient outcomes. The future possibilities, obviously, now is that for me is to personalize the intervention and the early intervention. We can actually personalize the duration of intervention. So not everybody having the fixed durations of intervention. And also mortality intervention. Some people might need more of family intervention. Some people might need more of individual CBT interventions, and also tailor to the different stages of illnesses. And then potentially there's a possibilities in the future for us to develop a data-informed prediction tools, taking into ongoing clinical information to assist the clinicians for their clinical care. So that's what I'm hoping that in the futures that we could pursue in our setting. So here are the two papers that I've presented or summarized today, and then feel free to scan the code to get the paper. I thought I'm doing the prediction model, so I needed to up my game for the high-tech technology. So putting the QR code here. And then I need to acknowledge all my partners in the studies, my funders, the Health and Medical Research Fund in Hong Kong, and all the research sites in Hong Kong, because we managed to do all the studies with the help from all the research, all the psychiatry sites in Hong Kong, and our research team and their collaborators that helps with all the studies and then the analysis as well. So, and also thank you for your attention as well. Thank you very much.
Well, thank you for a really informative talk and very exciting to hear how the work grew and what you're able now to kind of go into the data and kind of examine. I've got a few questions, but I'm going to hold off and see if there are questions. If you are remote, please use the Q&A to ask questions. I'll be monitoring that. I think a couple others will help me with that. And anyone in the room have any questions to ask?
Very nice talk, very excellent work.
Thank you.
Learned about in schizophrenia risk, suicide risk in early psychosis. That was not during the acute episode, but as the patients are recovering, they develop insight, and particular higher risk would be individuals who had previously better function. So kind of concept is that they get better, they realize what they've lost and where they stand, and that things become hopeless. Did you find your finding, I think, is that the more unstable the course, the higher the risk? Yes.
Yes.
Okay.
Yes. We didn't actually we didn't look into the insight. So whether it's because there's a line of research to debating on whether better insight, poorer outcomes in terms of suicide death, and also better premorbid functioning, and also that. So we didn't go into detail of that. But actually, the premorbid, in one of the slides showing the suicide mortality, we actually found a premorbid functional impairment predicts or associated with suicide death at the later stage, not so much in the first 3 years. But I think we will, because all these informations were obtained from the clinical records. So it's so we will need some more face-to-face interviews to obtain those information from sort of clinical insights. But that would it's difficult in a sense, because again, we will, in terms of suicide death, we need sufficient enough of sample size in order to do that. So it's kind of sort of difficult problems.
Other questions? You know, I found myself running the file, please.
I was going to comment a little bit from, thank you again for this presentation. Sherry and I spoke this morning a little bit about some of the ways that the RAISE project has impacted our clinical understanding and our expectations. There's good news that's come out of that, of course, but when I hear about obviously the suicide and mortality rates staying the same over a 10-year period, that to me feels like the bad news when we think about early intervention and how it's working. So I wonder, clinically, when we talk about suicide, one of the messages I try to convey to clinicians is that suicide 3 months after beginning treatment is different from suicide that happens 3 years into treatment, essentially 10 years into treatment. And from a research perspective, we may not have reduced the mortality rate. From a clinical and humanistic perspective, I convey the message that we may have extended a patient's life, and that those things are very different. So I wonder if that's something that comes up in the research, and certainly you're taking a very complex definition of mortality and suicide, and thinking about different events,
Right.
like self-harm and deliberate self-harm. But I wonder if that's reflected in your work.
Actually, the first study was purely looking at suicide mortality. And then we do find a significant impact of early intervention to reduce the suicide death during the first 3 years. It's just when you look at longer terms of 9 years, the effect was not significant during the 9 years. But if you count the whole 12 years, the effect is still significant. So it's just the significance effect over 12 years contributed mainly or only by the first 3 years effect.
And do you think that is because that's the period of active intervention? So if we continued coordinated specialty care for people with psychosis indefinitely over their lifespan, would we reduce suicide in this population?
I'm not sure,
Yeah.
because there are several issues coming into the pictures here. First is that first few years are the most vulnerable periods, and likely is the most cost effective in terms of the money you put in and the effect you get out. So therefore, you are likely to get more, we are likely to get more effect if we work on during this more vulnerable periods. If you continue to do the impact on that, would that still be impactful for people with schizophrenia as a whole? I think that's questionable. Because I think from my studies, I've already seen that some people actually do pretty well with very little interventions. Even the standard care group people with a very little intervention, they do well and remain well. But for the early intervention people, there are a group of people with very intensive interventions, they do well, but after withdrawal of these interventions, they do poorer. So in order to improve the schizophrenia patients' outcome as a whole group, I think the focus will be identify this special group and then put more effort or targeted interventions to this group so that money will be well spent. And then, so therefore, in the end, overall, the outcomes of the patients as a whole might also be improved. So that's what I was thinking.
Yeah. It always comes down in medicine to the rule of 30%, right?
Yes.
30% of patients do well after you and this is across, cardiac, right?
Yes.
Renal, 30% do well with the initial intervention, 30% do well with an intervention, but need something else.
Yes.
And 30% just don't do
Yes.
well with that initial intervention. And we see the same thing certainly with psychosis also.
Yes.
Carolyn.
Do you think it's a matter of severity? Because I noticed there was a difference at baseline in positive symptom severity, and then the fluctuation of those symptoms over time seemed to matter. So is it that patients who come in to the program with a higher severity of symptoms also have more to benefit from that kind of intervention?
The severity, baseline severity actually contributes. It's like indicating slightly poorer outcomes. And also our baseline is more of a, not baseline as such, but more of a during the first 1 month. So that's also probably reflecting, because if you are having a more severe symptoms, they're more likely to be hospitalized. And then you have to add the factors of hospitalization, that's positive and negative impact of hospitalization, etc. So therefore, it's the interpretations of that. I see that it could be quite complicated. But based on this studies, the information or the interpretations that severity of illness at the beginning and the response to the treatment at the very beginning, first few months, actually are already telling you how well the person is going to be in the future in terms of the mortality and then perhaps other outcomes as well.
Sophia, there's a question. There's a Q&A.
Oh. Maybe while I'm pulling it up here, Scott, you want to go ahead? Yeah.
Sure. So your data are very interesting. In this country, oftentimes access to lethal means is the primary predictor of suicide rate, or at least predictor future suicide. And so clinically, that's kind of, we're finally learning that that's the first concern when you get across is access to firearms. Physical lethal means at all in your study, and I'm sure it's very different. Like, I'm just wondering if you found further access.
Yeah, we didn't, to be honest, that's maybe our sort of bias. We didn't go on and to think about this line of work, because high buildings are everywhere. It's very difficult to stop people. So that's something, it doesn't come to my mind. but we do have in Hong Kong, drug overdose, Panadol use, and then we do have a sort of limitations of how much medication you can get. And then there's a period of time people tend to use charcoal. This is on top of the prevalence of jumping from heights as a means of suicide. But then other means like charcoal use, burning charcoals. So there were some sort of public health measurements not restricting people doing that, but more of a paying attention that who did that. And then also to sort of, because charcoal burning usually happens in the village. And then so then they know each other, and then some newcomers, so they will be more paying attention to that. So there are some public health measures to look at different other measures apart from the jumping to heights. But then our studies actually show jumping to heights nonetheless is the top on the list. And very difficult to actually do very much with that.
It's similar in San Francisco with respect to the Golden Gate Bridge.
Oh, yeah.
Really big issue, yeah.
Yeah, with the charcoal to asphyxiation stuff.
Yes.
Oh, I see. So they're.
Yeah, they close the door and then just burn the charcoal, yes.
We have a methodological question here from Michael Bronstein. Not surprising, he too is a data science geek. Well, shall I just call it what it is, Michael? So here's his comment. Thank you. If you see the QA, but thank you for the interesting talk. I have two questions. One, given that there are more people without versus with DSH, you have an imbalanced classification problem. Did you get similar results, same model performing best, when you look at the area under the precision recall curve? It's getting into a level of.
Yes, I couldn't see it.
I may suggest that he have a conversation with you offline, because I think I'll just read his second question, which is, given the importance of variability, the MSSD measure that you did, to predictive value, are any of your ongoing projects using denser assessment strategies, for example, ecological momentary assessment to measure psychosis symptoms to predict DSH?
Yes, so thank you so much for the questions. The second question is easier for me to answer and easier for me to understand. Yes, the answer is we are trying to sort of hoping to develop some ESM assessments. We had a little pilot to do that, the ESM, but then I have several issues with the ESM in terms of getting the symptoms. One issue is that ESM is mainly self-reported, whereas the current is that we get the clinical information from the clinical records, which is actually thinking about that. It's already filtered by the clinician. So they do that assessment, they documented it in the clinical notes. And typically the assessment is collecting information from both patients and their case managers or caregivers. So it's more of an already integrated information from the clinical records. So then we get the sort of wisdoms from the clinicians and extract those informations from the clinical records. So we can try, we will see how it goes with the more denser self-reported informations, how well they can actually inform us in terms of the self-harm informations. And also we have to also be very mindful is that my clinical experience are people actually wanting to really end their life, they don't actually see it. And so we might actually be, if we purely rely on self-report, we might actually miss some of those important information. So I actually do think that it's important to somehow have a form of integration. So self-report versus also the integrated sort of informations. Maybe that will help us a little more.
I'll put Michael and you in touch I'll put you and Michael in touch so you can communicate about some of the data methods together offline. So my question was, it's related to this sort of fluctuation in symptoms that you picked up on as having predictive value. And you can think about it in a number of different ways, and no one knows the answer, right? But I'm curious how you think about it, integrating your side of your mind, which is a researcher side of you, which is a clinician, you could think of it, okay, well, this is a form of psychosis or psychosis spectrum illness where their symptoms are fluctuating because we haven't figured out a good treatment for this individual. So their symptoms are sort of coming and going, and we're fiddling around trying to give them different treatments. So it may represent a unique, right, form. It could be that these are people who are having symptom fluctuations of this nature because they're not particularly adherent to their medications, which might imply that they have some issues related to insight or to denial or to rebelliousness or to accepting an illness identity, right? It could be, I mean, you could hypothesize that they have fluctuating symptoms because they have a more affective component, right, to their illness, and that hasn't yet been targeted in some way, and that puts them at higher risk for doing an impulsive suicidal gesture. So what are your thoughts about it? What hypotheses do you have, and what do you think is borne out clinically?
I think that's a really difficult question to think about it. I think it would be really nice to be able to get down to the bottom of why fluctuations of the symptoms, because what we can do now is only obtaining the phenomenon. Just look at the phenomenon that is the symptom fluctuation. So we are not able to detail to look at why it is so. As you mentioned, it could be multiple reasons, and I think perhaps that would be something that we can do later to dig deeper in terms of why people have these fluctuations of the symptoms. And I think another things I have to, I was actually thinking about what it means between relapse and fluctuation of symptoms. Then severe fluctuation of symptoms that require interventions, like like treatment and all that. Whereas, but then our patients, they do have a daily fluctuation sometimes. If you look at in details, or sometimes when they're under stresses, they might have a lot more hallucinations. When they are having good sleep and they're in a good period of mood and they have better symptoms controls. So I think those are the sort of fluctuation of symptoms that we are talking about. And I think those might be the areas that we can look into deeper with the EMA approach. So what happens, and then whether they have the symptoms. And then that would actually complementing to the sort of clinical records, information, and critics. So.
Yeah, and it occurred to me just as you were talking now that it might be possible for you potentially to test some of these hypotheses to extract from, if you haven't already, to extract from the medical record whether the individuals with these fluctuation symptoms are showing more changes in medications, having the medications change more frequently, or I don't know if there's anything in the medical record which indicates adherence or non-adherence, to see if there's any relationship there as well. Yeah. Steve?
I have some questions about clozapine.
Oh. Yes, my favorite.
Your favorite? Yes, me too. Is clozapine as widely used in Hong Kong as is in China? 20 to 25% of patients?
Not as widely used as in China, because you know that China, they've never stopped clozapine use despite of the issues that side effects related to clozapine. Hong Kong follows the UK guidelines, so therefore, in Hong Kong, in China, clozapine was considered as, or is still considered as a first line antipsychotics, but in Hong Kong, it is only used for treatment-resistant schizophrenia. We've actually published a study on the use of clozapine, I wouldn't say prevalence, but then use of clozapine among this particular cohort over 12 years. And then, the use of clozapine over 12 years, 15%. But treatment resistant is 15%, which is treatment resistant is 15%, which take into account of people who are treatment resistant but not using clozapine. So the clozapine usage rates 13%. If you look at the population-based studies in the Northern Europe, it's actually very similar. So although we typically in the literature says that 20 to 30% of people develop treatment resistant, which is typically using cross-sectional studies. So you examined cross-sectionally of the patients and see how many of them are treatment resistant, you get a figure around 20 to 40% and a wider range. But if you just look at the first episodes, the development of treatment resistance in our population is around 15%.
In the US, there's an FDA indication for suicidal behavior in schizophrenia and schizoaffective disorder. Is that the information utilized clinically? Is that believed in Hong Kong? And
it is not part of our guideline.
Okay.
So our guideline does not indicate the clozapine can be used for impulsivity, suicidality. So that is not part of it. And I think we are still struggle in terms of resolving or helping some barriers of prescribing clozapine for treatment-resistant population, because it's actually quite difficult to prescribe drugs. And then in Hong Kong, a lot of time people have to come into hospital to prescribe that. So it's pretty, they're still sort of trying to advocating for the clozapine prescriptions for treatment-resistant schizophrenia. So, but then the clinicians gradually seem to grasp the literatures about effect of clozapine and the mortality. And in our the same treatment-resistant publication, actually also show in our studies that the use of clozapine is related to reductions of mortality in our patients.
actual deaths, because
Actual
the
death.
US studies only showed reduction
In suicidality
behaviors.
behavioral, yes. In our studies, we actually show the actual death.
Wow.
Yes, but it's a still small sample. It's a capture of that. So we are actually moving on with the little small grants to look at the whole data set of Hong Kong. So we have like because the electronic health records, we can actually access the whole data set. So we now are looking into a more bigger sample, more comprehensive samples of the questions whether clozapine actually helps mortality rates in schizophrenia patients. So we are still, it's a work in progress right now.
Yeah.
So hopefully I will be able to share with you in soon.
Great, thank you.
There's another question about support providers in the chat.
Oh, in the chat, okay. Oh, this is about, this is a question, let's see it here from Melissa Dalho on that. Thank you so much for your talk. Suicide risk is ever present in our psychosis work, and our teams have experienced patients die by suicide, which takes a toll on team members. I'm curious if your teams have had someone die by suicide and how you personally and or your organization support team members following an event like this.
Yeah, this is always a very tragic event. And I think although rare, but whenever that happens, it's actually all the team members will have different emotion reactions towards that. And then so I must say that I don't think that we are doing that great a job in terms of managing the staff's emotions, because when that happens, the first instant or first reactions for our team is always to go out to check or to provide support to the families. So that's the first thing we do. And also we try to understand why this has happened. And so we're not exactly blaming anybody, but then trying to understand if there's anything that we could have done in the past to stop this. So to be honest, we didn't really put a lot of attention to the emotional support of our team members. But I think if this has happened to our junior members, like clinical psychiatrists, junior trainees, usually we will we'll have a chat with the senior trainees, or supervisors and the junior trainees. And I think the main thing is that try to help them not to blame themselves for missing something. That's the main hurdles that we have to help the junior trainees to get through that.
Yeah. I think as a field, we still have much
Yes,
to learn and figure out
exactly.
on how to offer each other support around these events. But yes,
I have kind of a difficult question maybe, but thinking about beyond psychosis and first episode psychosis, where do you see generalizability to other pathology, but even non-diagnosed, people who died by suicide who weren't hospitalized, weren't in a kind of formal mental health system? Is there things that your research tells you about what might help reduce suicidality in that population?
Yes, indeed. I think this is very difficult questions because suicide in general population, it could be more heterogeneous than our clinical population. So I dare not to go into that area because knowing that it's going to be very complicated. But what I understand is that now, so that a lot of research actually going towards that aspect, general population, sort of not looking at that diagnosis. So just the general population, their suicidalities and self-harm. And I think the environmental, social factors, economy, stress coping, personality, these are all very important factors contributing from what I understand. And I think, as I mentioned, a lot of prediction models actually and then also adolescent is the most vulnerable sort of age populations compared to, like, if you look at the population as a whole. But obviously elderly suicide is another topic as well. But then so there are a lot of research now, prediction models is actually going into just the general population. And then as far as I understand it, looking at the literature, those machine learning prediction models seems to be also not too bad, getting into the predicting the self-harm, again, using all sort of available information on the records. And then also chatbots, development of chatbots to tap out people's suicidal behaviors, and also using all the social media. So there are a lot of studies going into that directions, more sort of natural language processing, so the social media's output and all that. So I think this is a whole different arenas of research indeed to look at that, and then very important public health importance.
yeah, Katie has left now, but I found myself wondering if she found parallels between some of your findings and some of what is known in adolescent depression, but we'll have to save that for a question for another time. Well, good. I think this is a great place to pause. Thank you very much again. Lovely presentation, great discussion. Great to have so many people here in person asking questions, and we've got kind of the education and academic mission of the department. It feels like kickstarted again after a long lapse. So this is great. Thank you very much, Sherry. Thank you.